Okay, welcome to our DCRI seminar series. It's my pleasure to introduce Dr. Peter Wilson to you. Usually I try to memorize my introductions, but with Dr. Wilson it's just too much stuff to memorize, so I'll have to have a little cheat sheet. Dr. Wilson is a professor of medicine, Division of Cardiology at Emory University, and a professor of public health, global health and epidemiology focus in the Rollins School of Public Health at Emory, and director of epidemiology and genomic medicine at the Atlanta VA Medical Center. An interesting piece of information, his postgraduate medical training took place at Duke University. He is board certified in internal medicine and endocrinology. And Peter and I overlap with the Framingham Heart Study, where he was the director of laboratories and I was a humble statistician. We worked together on a number of time. Peter authored probably the most famous Framingham paper to date, and that might mean ever, on the prediction of 10-year risk of coronary heart disease, which received, I believe, over 10,000 citations. It might be one of the most cited papers in history of medicine. He is an active member of several societies and holds leadership and director positions. I won't read all of them. His research focuses on metabolic and cardiovascular disease in populations. He's an active clinician on inpatient, outpatient services for internal medicine, endocrinology, and lipidology. He's an author and co-author of more than 550 scientific articles and four books. And he will talk to us about a very relevant topic that a lot of us are working on relating to diabetes and cardiovascular disease. So welcome, okay, Peter.
Great. You keep that. I have a mic, I guess. I should be. Can you hear me all? Fine? Okay. I've done a conference here at DCRI 5 years ago. And when Michael and I were discussing the topic for this talk, I said, how about diabetes and heart disease? Because that's a very ripe topic, I think. And I'm glad I picked that, because often people ask me to speak about prediction of heart disease, but you now have Michael Pincina, so I'm very careful about coming here and speaking about it with Michael. And also, I gave that talk here 5 years ago, and you've already heard that talk from me, so go with Michael. So I guess I'd do better. Can I stand here, or I'm not a behind the podium person, but I have to turn around to see the slides, I guess, when I get to this. So I have no disclosures. This is the outline. I'm going to have to come back here to see the slides, though. So the principle of this is to go through the critical risk factors for heart disease in diabetic patients and to give you the flavor where diabetes changes the flavor of what we're tasting and what we're caring for. And it's not exactly the same as for non-diabetics. And it makes an effort to meld the American Heart Association, the ACC, and the American Diabetes Association guidelines that have all come out in the last couple of years. Okay? So first of all, as a reminder, there are going to be some clinical reminders in this talk. It has an elements of a medicine grand rounds as well as a research rounds. Is the type 2 diabetes is different from type 1. And we have an epidemic of type 2 diabetes. Type 2 diabetes, the typical patient who's being seen on the wards or having an event in a cardiovascular study has probably had diabetes 5 to 15 years. Some studies, for instance, I'm going to throw pearls out as we go along. You might or might not be aware of the United Kingdom PDS, the UK PDS, and you've had colleagues like Rory Holman and others who've participated in that trial. They took new onset type 2 diabetes. So it was really an unfair associations because they didn't have typical duration of diabetes such as what we might see in a clinical setting. But as you can see there, most of the risk factors are a heavier burden than type 2. Type 1, our patients are doing exceptionally well. John Buzet, former president of AADA down at UNC, not far from here, has said we've changed the scope entirely for type 1. We have not at all for type 2. This is the big burden of cardiovascular events. Now this slide was put together 1995, saying that 65% 65% of cardiovascular events are seen, every diabetic, if you take 100 of them, 65 of those 100 will develop cardiovascular disease prior to death. By the end of this talk, I think you're going to realize that's probably a conservative estimate, at least from a Framingham perspective. It's a higher number than that. Now, starting out is, what is the burden? And what are we did this initially with Framingham analyses with relative risks. And as you can see here, the risk if you have no diabetes, this is a relative risk, so is 1 in the non-diabetic. So the rule of thumb here for age 35 to 64-year-olds at baseline who are followed over long term is about a doubling of risk for men and a tripling or more of risk for women. And as you can see, some of these outcomes, it really takes off. Cardiac failure, we had follow-up analyses, especially post-MI. Both the men and the women were going into cardiac failure if they had diabetes mellitus. Now, if you go to an older age group, 65 to 94-year-olds, you have more of a doubling, not a tripling of risk. So it's an evening out. And then this is using an older definition of diabetes. So this is where diabetes was diagnosed with a fasting glucose greater than 140. And we've now moved to 126. So this is a common question I ask fellows. Do you think this is still true? These analyses in general have not been updated, but that's an unresolved question. Do we still have a doubling or a tripling of risk? And the answer is probably no. We're now getting down to lower relative risk because it's easier to become a diabetic in the year 2015 than it was in 1995. So because we have a greater burden of diabetes, but diabetes now includes lower glucose levels. This is the most famous slide related to glucose, diabetes, and heart disease risk in the history of the field over the last 20 years. It was developed by Steve Hafner. It was when he was a visiting professor in Finland, and he came back. He relates how he wrote the paper on the plane and was almost ready to submit because the flight was so long when he came back, comparing diabetics and non-diabetics in a Finnish cohort and their risk for who got a next myocardial infarction. And inside the yellow rectangle is the non-diabetic who's already had a prior MI and the diabetic who has not had an MI. And the concept was created that this was a risk equivalent for a myocardial infarction or for coronary disease. And that drove part of the guidelines that came out in 2001, which was led by Scott Grundy. In fact, if you read the most recent guidelines, this is not mentioned so much anymore as a CHD risk equivalent. And it's because of this meta-analysis that was done by an Indian investigator, came out in 2009. And as you can see, all those studies over to the left, diabetes is not a CHD risk equivalent. That's where the most of the data are. The majority of the data are really far over to the left. And it's probably the most unusual analysis in that the Sentinel papers, Frank Hu's and Steve Hafner's papers, and even Steve Hafner's paper originally overlaps with a null effect, are outliers. So something that changed a guideline in 2000, leading up to 2001, has now been reversed and no longer felt to be true. So that's why we don't see this so much in the literature. I'm going to go through a variety of other things since we've now done a background, and I'm going to try to highlight things as we're going along. So first is lipids. A common question I ask endocrine and cardiology fellows, what do you think the LDL cholesterol in diabetic patients? We're aggressive in diabetics, so it's got to be higher, doesn't it? No, this slide shows, this is from Framingham data from Richard Siegel when he was a fellow, but it's pretty much been replicated around the world, is that the LDL cholesterol is greater than 160 are just as common in diabetic and non-diabetics. It's the other things. In fact, that was a loaded question. If you answered no, but it's everything else, you would have been closer to right. So it's the triglycerides, it's the HDL, it's the clustering of risk factors, which are really different in diabetics. Now, the LDL particle number, that's not on this slide, and that's a newer science finding popularized by scientists right here in Raleigh area, LDL particle number is higher in diabetics, and that's been seen also in multiple studies. But the simple old-fashioned LDL cholesterol is really not that much different. Now that holds for men. What about for women? Is it going to be the same? And the answer is no. It's greater tendency towards abnormal lipids. And this is probably more than any other reason why type 2 diabetic women get premature heart disease. Remember that 35 to 64-year-old group? Women prior to menopause really don't have much of a risk for heart disease unless they're diabetic. And it's especially these women who have the abnormal lipids. Again, it's mostly the clusters where you see the greatest differences. Now that's observational background data. What about trial data too? This is the first blockbuster trial that included diabetics and had separate analyses within diabetics. This is Calevi-Piola's analysis within the 4S trial, which was the simvastatin trial. And as you can see, the group you really don't want to be in is diabetics on placebo. They really fared much worse than all the other groups. And that difference between that diabetic placebo arm and all the others, nobody's ever equaled this. But this was in an era when you had very lipid treatment naive individuals, and we've really changed that now. I'm going to be mostly statin-centric because most of our guidelines are statin-centric, but what about other subgroups or other issues? For instance, can you give a fibrate to prevent heart disease in a diabetic group? And this is a subgroup analysis. And you have to go to subgroups to start to see the triglyceride HDL effects. This is Hannah Rubin's paper looking at the diabetes versus non-diabetics, and virtually the same hazard ratio change. 24% favorable effect, which is fairly similar to what you're going to see in the statins. So this is the statin data. This is another thing that I say to patients every day when I see them in clinic. I say, do you understand why you're taking the statin, for instance, versus not taking a statin? Because a lot of patients say, I don't want to take the medicines. I've heard that may cause muscle cramps. And I said, you're taking it because it's going to lower your risk about 25%. Here it's 23% because of a 77% hazard ratio. So 23% advantage versus the next patient who doesn't take a statin. So, and it's, again, about the same effect in a diabetic patient versus a non-diabetic patient. Now let's go back a little bit to the fibrates. As you can see here, this slide and the next one would suggest, as you can see, that middle column, Helsinki and VA had some diabetics. BIP, bezafibrate, not available in the United States, had some diabetics, but did not have a significant p-value. So there's always been a hint, ever since we had early monotherapies with non-statin therapies, that a fibrate may work. And this has been especially highlighted. This is from Alison Goldfein's commentary in New England Journal a few years ago, and it brought up the concept of these subgroups. And lipidologists are very aware of these because of the subgroup analyses within Field and Accord. And there's another trial in the making. It's called VA FIT, which is a VA phenofibrate intervention trial, which has been planned and hopefully will take place starting either this year, 2015, or 2016, provided all the VA funding and sponsor funding goes forward. It's particularly addressed the low HDL, high trig patients who already will be taking a statin. Of course, we've had many statin trials adding a second molecule that have not been positive, but they've not really focused quite this way with the initial plan to study these groups. So in summary, this is, for those who don't like looking at figures, this is just text. LDL cholesterol, statin at maximum tolerated dose. That's part of the new guideline. The ADA went along with that with their update that came out early 2015. And then you can see these other second choices. No real directive for what to do for HDL raising for diabetics or non-diabetics. We have some CETP inhibitors, but we still haven't had a positive trial. Had some evidence of harm. And triglyceride lowering, I think the focus on is that very bottom line. Triglyceride lowering less than 500, there's no recommendation to use additional medications. Above 500, yes, lifestyle medications. But below 500, don't have the answer yet, and there are a couple of omega-3 trials that are addressing that. So this is if you can't remember the new guidelines, maybe you'll at least remember the middle panel here, the old guidelines, and you see what's different. So we no longer say risk equivalent. We now consider all those greater than 40 with high risk. LDL less than 100, and then it's less than 70 in some. We no longer really target that. There's nothing wrong with a physician who wants to do that, but it's not dictated in a guideline. And then no real fixed targets. So when do you measure LDL cholesterol? I'll get to that in a subsequent slide, but we don't give explicit recommendations for that. This is what the ADA then came out. This is a really nice figure, I think, that just came out earlier this year, taking three age groups, risk factor burden, statin dose, and the need for lipid monitoring. And as you can see here, I think the thing to focus is on the center. As diabetics under age 40, it says none. So there's a gap there, isn't there? When does a type 1 diabetic start taking a statin? We don't have any recommendation. You start reading the guideline carefully, line for line, you will not find it. And things sort of magically change when you get to 40. I don't think so, but that's what the guidelines say. And then almost every other group is moderate or high, and you can read there as according to the risk factor burden and age combination. And then when you get to especially high, is perhaps be a little more conservative. This is to remind the clinicians. I say to the cardiology fellows, you only have to remember the names of the high intensity daily statins. They're 50% LDL lowering drugs, and you can see the two names there. Most of the drugs and the doses we're prescribing are factor of moderate intensity, and then some of our patients can't handle that, so we're using the lower intensity. One of the questions that comes up, though, is let's say you have somebody on pravastatin 10, 20, or 40, and they're having a very good response. Should you switch that person to a high-intensity statin if the guidelines said that? We don't have an answer for that. That's another one where we don't have an answer for. You have to actually practice medicine and make a decision yourself as a clinician working with a patient, what is the next step. Now, John Guyton's in the audience, and he and I could debate that for quite a while, but that's an example where we want physicians to think what they're doing for their patients and not rigidly adhere to guidelines. What about blood pressure? The JNC7 made the recommendation that we should be treating diabetic patients to less than 130/80. So that was a post hoc analysis from the Hypertension Optimal Treatment Trial, the HOT trial. And as you can see, there are 48% reduction for people who are titrated to that level diastolic after 1 year of therapy in a largely non-US trial. And as you can see here, yellow, orange, red is the color code to highlight that. And the idea is you might want to really be in that red group. You have a diastolic less than 80, you're going to benefit. Now that benefit did not accrue in the non-diabetics. So the JNC advisory committee that came out, that was about 8 or 9 years ago, recommended less than 130/80, especially focusing on the 80. And then this went across more than one cardiovascular disease endpoint. As you can see, major CVD, MI, CVD mortality. But then what happened with the next set of guidelines? The joint ACC-AHA guidelines that came out now about 1.5 years ago. As was put to all the guidelines groups that deliberated over the last 5 years, is we need to be evidence-driven and not allow post hoc analyses go into guideline development. Really primary associations, especially in clinical trials, with the primary intention. Remember, there was a largely intention to treat. And then key, large, well-constructed meta-analyses were considered the critical elements for guideline development. So HOT was a post hoc single trial, not a guideline driving type of product of research that should really dictate what would happen in the future. So they decided they were going to pay less attention to that. And they got fuel from other sources. So here's an example for intensive care. This is within the ACCORD trial. This is an NIH-sponsored trial, lowering blood pressure. Really, as you can see there in the bottom right, if you take a target, as you can see, less than 120 versus less than 140 systolic, it didn't have a extra benefit. So they're saying that happened after they already had issued JNC7. They said, well, gee, maybe we overreached. And that's what led to the ADA recommendations and others. And I think this, in fact, lays it out as well as the ACC-AHA lifestyle for virtually all adults. And I won't read through those. But then you get into the 140 over 90 versus 130 over 80. So the HOT was considered post hoc. So most patients, they backed off. That's very different. We always think guidelines are getting tighter. In fact, they backed off in this one. And 140 over 90 is the target for most diabetic patients. And the rule of thumb for those with the more strict definition, the 130 over 80, is those with long life expectancy. And you'll see that term more and more in the ADA guidelines, is the 20-year-old, the 40-year-old, those who you expect really could have a quite long livelihood. Maybe lean towards those, but then it doesn't exactly say which person. You have to decide that person has a longer life expectancy. So it brings in elements of the art of medicine. Additionally, I think most of the clinicians are aware of this as ACE or ARBs for angiotensin blockade, and you have to have some monitoring, and then at lower levels of glomerular filtration, adding loop diuretics. Another cardinal one is the most diabetic patients are undertreated for hypertension. And if you go to any cardiology meetings and you sit in the back and listen to our hypertension experts, they make the point that the average number of medications is 3 to control a diabetic patient. And most patients who come to my clinic and I'm helping to regulate their blood pressure, almost nobody arrives on 3 medicines. They're usually on 1 or 2. And that's the first step, is to add a third. And then the most common one that's missing is a diuretic. Antiplatelet therapy. Should we be handing out aspirin to our diabetic patients? Well, you folks are doing a trial. You're getting ready to do a trial. So maybe I should beg off on that, but I'll show you what's there right now. So this is a meta-analysis, the data from it, and there was a statement, a joint ADA-AHA statement by a large group of people from both organizations. And I always tell patients aspirin is generally a 10% drug. Remember, lipid lowering is a 20 to 25% intervention. So then you say, well, I'm actually reading this slide carefully. It says 0.90, that's 10%, I get that. But the confidence interval includes 1. And Michael Pignoni, who did the meta-analysis, says, yeah, there weren't enough diabetics in these studies. Even look at all those studies, 9 studies, there weren't enough. So it's in the right direction, same general effect as in non-diabetics. But then if you read through and you really start to look between the lines for those at lower risk, aspirin doesn't do much for low-risk diabetic patients. So that's number 1. And then secondarily, if you look, and you can do these with plots, you do the meta-analyses and then you line up all the studies according to the year of publication or the year when data were collected. You get into the statin era, there's a good bet that the aspirin effect is going to be less. So I'll be very interested, you folks, as you move forward with the adaptability trial with Matt Rowe and others, are you going to get a 10% favorable effect in the statin era? You need a big trial to show this on top of statins, but I think you're addressing one of the gaps. There's another trial NIH is sponsoring looking at aspirin, not at different doses. You're looking at different doses in this new trial, but there's 100 milligrams versus placebo in the elderly. That's also still considered an unanswered question, especially diabetic elderly, with more than cardiovascular disease as the outcome, also looking at cognitive function and at cancer risk. So this is real. I really like this table because it lays it out so clearly. What do you do for aspirin? What is ADA recommending? Very low risk, no aspirin. As you can see, the rest of them, everybody agrees with higher risk people, and hopefully you're going to add more definitive answers, even within diabetic subgroups. And aspirin intolerance, going to other agents, and then for patients who are on stents, aspirin plus dual antiplatelet therapy. Now this is the most controversial. And this is where you've had some trials and demonstration studies, and I've been on the edge of this because I serve on an FDA panel that reviews some of these results. And what about diabetes and heart disease? And what about glucose control? What do I tell my patients why they're taking certain glucose program for control versus others? So for microvascular disease, which is in orange here, the gradient is fairly strong, especially going from 7 up to 11. And you say, well, it stops at 11. I have patients higher than 11. Yep, I've got several myself, 12, 13 patients who are difficult to control, who don't keep appointments, et cetera. But there's a strong gradient from microvascular disease, which is eye and kidney disease. So especially retinopathy, kidney function, and albuminuria. But as you can see, it's a little flatter. So this is from the UK PDS study. And as I said, these are early in the talk, that these are people who, just as they started diabetes. So we, in fact, don't have as much robust data on this topic as we would like to for people who have had diabetes for 10 or 15 years. And this is, of course, all type 2 from that trial. Now, this is an example. This is how the Danes do Mr. Fit. They did it at the Steno group, which is a clinic in Copenhagen. And the 2 is to stand for type 2 diabetes. And they had conventional therapy versus intensive. And as you can see underneath the intensive, targeting a fairly aggressive A1C, less than 6.5, relatively low cholesterol, trigs, and blood pressure, which was, when this trial was started, now about 15 years ago, was aggressive. And they did this with only a few hundred people. It's been considered the poster child of a really efficient small trial in type 2 diabetic patients. The A1C was about 9 when they started, though. So we don't start there anymore. And that's affected the interpretation. You would say, I certainly want to be in the intensive arm. So that's what the ACCORD trial did. So the ACCORD trial looked at A1C, cholesterol, and blood pressure, and all 3 arms of that, individualized, were null in the United States with a trial that came several years later. But when they started earlier, this was the 2008 results with 13 years of follow-up. So the trial had to start at least in 1995 or earlier. They had a big win in the Steno 2 group. So it's always been considered an excellent study, but perhaps we've moved into a different era. This is largely the pre-statin era as well. So then the ACCORD trial. Now this was unusually disappointing. You can see the effect of usual care versus intensive care for glycemia, and they targeted A1C because they already had inklings of what was happening in the Steno trial in the earlier reports versus usual care. The usual care is pretty much now even the usual care. So this was trying to really push on glucose. An A1C of 6 means that you're spending a lot of your time less than 120 glucose in your bloodstream. And you may have higher risk of hypoglycemia. And that's probably what happened, although they still never have sorted it out to this day. And the trial was stopped early because of the red-lettered 1.22 hazard ratio for death risk. The primary endpoint was MACE per year over the course of the trial, but the trial was stopped early. And as you can see, that was going in the right direction, a 10% favorable effect. But the trial got stopped early because of the harm caused with probably hypoglycemia with multiple medications. So that's made us all back off on A1C. And I think, I'll come back to this for what we really should be doing for patients, but less than 7 should be considered with caution, I think, ever since this trial came out. Then we had other things coming out in the last 4 or 5 years. The one that was the sentinel event was probably this meta-analysis by Steve Nissen and colleagues looking at MI and CVD death. As part of FDA hearings data, they relied on a lot of unpublished data and aggregated it. It got a lot of attention. As you can see, a 40%, 43%, 64% increase for people taking rosiglitazone. Now, this is a thiazolidine dione, a TZD drug, works on insulin resistance to improve it. improves glucose. It's a good drug, but it also has been associated, early on, everybody knew it was associated with increased fluid accumulation. Now, his meta-analysis focused on MI and CVD death, but it's incredible. If you look at the next 3 or 4 years after that, there were about 5 meta-analyses. And this is one of them. This is in the Lancet that shortly came after that. Overall, a null effect, not agreeing with them. Rosiglitazone, a null effect. And PO, a null effect, all for CVD death. That was one of the outcomes that he had considered. But this was probably the big ticket item, so to speak, and almost everybody agrees with this at this point, is increased heart failure risk. Especially this is people who are vulnerable for fluid accumulations, and it pushes them into clinical heart failure for overall and for each subgroup, as you can see here highlighted with the red arrows. And this drug went under a cloud, a very dark cloud, for 5 or 6 years, had an AHA statement on it, concerned that maybe it was really restricted to heart, and then was cleared by an FDA announcement about 2 years ago. It's safe, it does not have any adverse harm for ASCVD, but does have increased risk for heart failure. So it affected how we dose those drugs. All right. So we're going to, as we go into this, that changed the whole field, is how we approach these new drugs. And I'm going to give you some highlights of some of these new drugs. Their probably list is almost twice as long as this, but I'm going to just highlight some of them. Biguanides, metformin, increased CVD. Is that true? Well, that's in some of the summaries. In fact, there's a trial right now to suggest metformin may decrease CVD. Greg Schwartz is leading a major VA trial that's going to address this question. There have been NIH special announcements to try to look at smaller dose metformin may in fact improve CVD risk. And it's part of the reason why we keep metformin on patients' treatment programs even as they add second or third drugs for diabetes treatment. Glipizides and glyburide, a whole bunch of other sulfonylureas. These are the key drugs other than insulin that cause hypoglycemia. We're trying to develop more and more drugs that do not cause hypoglycemia because this is really thought to be a key adverse event that may be associated with increased mortality in these trials. The TZDs we've already discussed. I think we've said all those key points. And then to start getting to the areas where you've had some trials recently with the TCOS trial. This is an example with the DPP-4s. There were signals coming through, and I'm going to show you further data on that, for increased hospitalization and the need perhaps for safety trials. But there are others. Here's a couple more. Exenatide, that's an excellent drug. It's also an injectable, which is a barrier. Decreased weight, but you know, that's a problem. Not everybody wants to have an injection. And then more recently is the canagliflozins. These work on the tubular maximum of the kidney. So in fact, you spill more glucose in your urine. You have a sugared urine, more urinary infections, vaginal infections. And then only in the last 3 weeks, ketoacidosis, 20 cases in the last 6 months, the FDA reported. I haven't seen a black box warning on that drug yet, but it may be coming. So then this is one of the topics that I'm going to, with apologies, I'll show you some of your own data, at least one or two lines of data from DCRI. But it's important to understand what happened in 2008, shortly after the TZD concern with heart failure and the Nissen and other meta-analyses, the FDA issued a guidance. And I'm not going to read all of this. You can read it better than me. But the point is, if you get down to the bottom of this, is that there needs to be safety studies. And these safety studies need to be fairly large. They're after drugs have been approved or as they're being approved. And you have to have great confidence delivered to prescribing physicians that these medications are safe. And that you, for instance, you may win the glucose war but lose the heart disease war. That's sort of the easier way to simplify it. And you get into hazard ratios, for instance, less than 1.3, which is very conservative. And then, and I pulled this, if you look at line 4 there, those are the blinded adjudication, and as you see, there are several events, and then at the end of that, it says possibly others. It never says heart failure in this guidance. And heart failure is now one of those possibly others, and often not extremely well adjudicated because it's heart failure hospitalization. It means that was on your discharge diagnosis. So here's an example. This is the two studies that kicked it off are SAVOR and EXAMINE. These were reviewed by FDA about 3 months ago. And in the deliberation and the vote was in favor of, well, SAVOR really seems to show an unfavorable signal. And at 1.3, gosh, we are up to 1.5 with a hazard ratio. And then EXAMINE, which was with allogliptin, less. And the FDA, at the end of the deliberations, they didn't say it, but they privately, if you asked them what was the next step, and they said the next step is TCOS. And we will not issue a pronouncement at all until TCOS comes out. And as many of the people in the room here have been involved with TCOS, it was no. So I'd like to think that perhaps we're closing the door on the safety of the DPP-4 gliptin drugs, and they're safe. But we'll see what the FDA issues probably later this summer is my guess. So, moving on, inpatient glucose control. Stress hyperglycemia is on the units, in the CCU, the ICU. When I'm on inpatient endocrinology, I'm helping to titrate those along with endocrine fellows. It's twice rounding a day, lots of glucose data. And in fact, in our hands, at our hospital, the best performance is done where we have the best nurses. And the best nurses, interestingly, this is anecdotal, not science, the best nurses are the surgical ICU nurses because the surgeons are empowering the physician's assistants and the senior nurses to run the protocol themselves without much intervention by clinicians. And I think that's an anecdote which hasn't been very well tested, but actually may bear on what I'm going to show you here. So this is the key part of this puzzle. So the first paper that came out on this topic was by Van in a surgical ICU showing that lowering glucose, being aggressive in the ICUs. Now this is ICUs in 2000 to 2005, 6, 7 range in Belgium. Not all the stuff that we have available for our units with all the electronics and most US ICUs. But as you can see here again, a sentinel clinical trial, generally not that well replicated, but he had such a big trial, it ends up still driving the overall impression of, gee, that's a good thing to do. But then this is the most recent well done meta-analysis I've come across. Now I'm going to be reminded I've missed one, and somebody's going to tell me this is a little wrong. But so they're still hanging in there with this data. That was from, but all the other groups, we go into other ICUs, they're not replicating this. So in general, what this has led to in American ICUs, at least where you have endocrine and diabetes support, is that we are not driving glucose extremely low, and we're targeting 140 to 180 milligrams per deciliter. We're using insulin drips, and endocrine fellows are writing the orders for patients as they're transferred off the units and into the wards. The biggest problem is the handoff as they go to the wards, and somebody fumbles the ball, and the patient often gets hypoglycemia if they're not watched real carefully. So this is what the American guidelines say for those two elements. Is I mentioned the 7 for most patients, that relaxed for older, sicker patients. I give a rule of thumb, if the patient's close to 80, think A1C of 8, that's an easy one to remember, and something the patient can now, as they're switching from 60 70 years old to 80 years old, that they say, oh, you don't want me to get hypoglycemia, and that's a little easier on them. And I just mentioned the threshold 140 to 180 in the hospital. Revascularization, where do we stand on that? Just a few words. And so there have been 2 or 3 key studies. There have been a lot of meta-analyses and reviews that are not trial-based, but this was the first key trial, the bypass angioplasty revascularization investigation study, a real mouthful, 25%, but you would prefer, if you were a diabetic patient, to be in the CABG group and get coronary bypass. So you can see 18 versus 25, that's about 8 over 25. That's a big difference in terms of percentages, 30% advantage to be in the CABG group. And that led to a follow-up study. And that was an NIH study. And then the Berry 2D, which stands for type 2 diabetes. And you can see the inclusion, all diabetics. It included insulin providing, insulin sensitizing, cabbage, PCI, and a whole variety of sub-analyses. But the key was this one stratum, is that patients did better, again, with cabbage, and especially if they got revascularized compared to medical therapy. Now, this continues to be debated, and other groups have medical diabetes subgroups, but we still lean towards a cabbage in our patients. But then if you talk to your cardiology colleagues and your CT surgeons, and they remind you, well, Peter, we've moved to hybrid. Those are using stents that were 7 or 8 years old now. So if they have a left main, we do a cabbage. And then if they have other lesions, we go ahead and do stenting. Maybe some of you in the room know there's a trial that's really addressing that or providing good outcome data on that. I think we're ready to hear more about it. I don't know if we'll get a special trial to address this, but that's still that we have now moved into an era where our clinicians are no longer satisfied with that result, and they want a hybrid approach. So generally preferred, though, is what you'll see in most of these guidelines. We're a little out of the loop some of the times because the surgeon may be involved very soon, and he's going to generally lean on doing a cabbage, as you might guess. And then the last topic, obesity. Most of our type 2 diabetic patients are obese. That's partly how they became diabetic, along with their other risk factor burden. But as I remember, I said I was going to remind you of, I thought that 65% was relatively conservative. So these were Framingham participants, women on the left, men on the right, follow up with the longest duration in the back row. And I don't think any of us really want to be in the reds, a man or a woman in the red, with increasing BMI, less than 25 to the higher ones, greater than 30. And as you can see, the estimate for the women is 79%, and for men, 87% will get cardiovascular disease prior to death if they're followed long enough. So it's almost all of our diabetic patients are eventually going to get cardiovascular disease. Now, of course, you got to do a trial. And NIH did a trial on this. It's the Look Ahead trial, an expensive long-term trial. It went out 10 years. And this shows 10 years of data that were accrued for weight, waist circumference, physical fitness. They only had measures up to 4 years, and then A1C. And as you can see, they had great separation the first 2 or 3 years. And as the trial went on longer and longer, it was harder to separate the groups with the intervention versus the control group. And then just up here in the top right, it was null. So a 5% effect, it was null. And so all we can say for our with type 2 diabetes is work on it, lifestyle, exercise, but we cannot show a proven benefit for cardiovascular disease outcomes. So that's my last slide here, for you to dwell a little bit on the topics in 1 line or less, or 2 lines, I apologize. This is where we are. This is the American Diabetes Association, and they largely build on the ACC-AHA, but there are some differences, as you can see, and they make efforts to be evidence-driven. So thanks very much.
Thank you very much, and now we'll open it to questions.
Peter, thanks for that. And I'm quite interested in the difference between really long-term outcomes, 20 and 30-year outcomes, versus year-by-year outcomes. And I'll use a diabetes example. In a cohort, it looks like the effect on the lesions might be favorable, in the sense that the MACE were had to trend toward favorable outcome, but your risk of hypoglycemia is an immediate thing. And I guess the question really is, how can we begin to sort that out and understand the difference between that immediate short-term risk and perhaps the long-term favorable outcome?
All right, so as I understand the question, you want to sort separate short-term versus longer outcomes. And I would say we're going to, like many things in diabetes, I think we will pass through that into new science. And I hinted at that with the glucose drugs. So around the world, after metformin, and in some parts of the world, sulfonylureas are the key drugs, by far. Nothing else touches them. They're so inexpensive. And diabetes drugs, oral drugs, are being developed at the rate of about 1 per year to 1 every 2 years. And I showed you most of the key new ones, but we're going to get more. And I think the hazard is hypoglycemia in outpatients. That was where the real problem with Accord. And I think we're moving in the direction we're going to try to limit hypoglycemic drugs in our diabetic patients on oral medicines as much as we can. That's clearly the direction that we're going. And in the hospital, for instance, hypoglycemia is a reportable event in every hospital. Every chief of endocrinology gets a printout on a regular basis for how many episodes there were in the hospital each week. And if they're recurring in some places, they have to develop a remediation program, training physicians and nurses so it doesn't happen. The big issue, I think, is for our vulnerable patients is hypoglycemia. That's my personal guess. We didn't sort it out for Accord. Since the investigators haven't sorted it out now, I don't think they are going to sort it out. But for instance, Guillermo Ampieres at Emory has developed rabbit protocols, which are bolus and basal bolus insulins, using insulin with protocols in hospitals so that outside of endocrinology there's greater comfort. But he's now even moving, he says, there's a risk with that of hypoglycemia. So he's now moving even more towards glargine, long-acting insulin, with these other new drugs. The oral agents in hospital use, and he's developing research protocols to look at in-hospital safety and not having to have these glucose teams see the patients twice a day. And that's just getting going. Of course, Pierres was really concerned about the signal with the DPP-4. So I'm not sure I would be prescribing this patient to DPP-4s inpatient with a history of heart failure. But if I don't think they're going to go into heart failure at all, I think you're going to see he's already working on protocols to address that. So I think the question you have is very valid, but we're going to address it by moving forward with newer molecules and different science.
Hey, Peter, that was a great overview of a lot of interesting important work. I guess, 2 questions. One is sort of a methodologic thing that I've been gnawing on for a while, and I'd be interested in your opinion, and that is diabetes, like hypertension and some other sort of risk factor type diseases that we deal with a lot, is not really a homogeneous entity, as you've alluded to. But a lot of this research and guidelines tends to treat it as if it is. There are other diseases which are staged, in which the stage matters a lot to the treatment. Why don't we do more of that in diabetes? Do we know how to stage diabetes in a way that's meaningful to the risk of the patient and the appropriate intensity of the treatment? And my other question just deals with an email that I got that pointed out that the average woman now weighs what the average man did in 1960, according to the CDC. And so, for part of this problem, we've just got this epidemic of expanding people. And is it, it just feels like the wrong to invest in a lot of expensive pharmacology that's got complexity to it when you're sort of at the other end of the problem. Well, shouldn't we be intensively trying to do something about where this is coming from?
Right. So there are 2 questions there. The first one was, could we get better at identifying diabetic patients at higher risk and maybe for specific outcomes, if I were to paraphrase that a little bit. We do not have good algorithms to identify this. We have also something that, well, I was on the American Diabetes Association Guideline Committee about 4 or 5 years ago, is we have no guidelines for screening for diabetic patients, type 1s or type 2s. And should we? We don't have the data to support any screening. But the other thing that has happened, and you're indirectly alluding to it, and I didn't talk much about heart failure in this talk, I was mostly focusing on atherosclerotic disease, is that diabetic patients now go into heart failure, not through the front door, but through the side door, I call it. And I think the cardiologists know what I talk about. When I was in training, a person would have a heart attack and then he'd go into heart failure, and especially if it was a diabetic patient. Now he doesn't have the heart attack. He just has long-term hypertension, not so good glucose control, many, many years of diabetes, and his heart muscle and or his microvascular in the heart is affecting his cardiac function, and he slides both into systolic and diastolic failure. So, and that's our huge burden, as you know and I know, all of us who keep track of incidents. And when we're on the wards, a third of the patients, even on a medical ward, are on heart failure. It's just the most expensive diagnostic group. So that's number one, is how can we identify those people at greater risk? We're going to be forced to do that for care with a 30-day readmission, because these people are going out and then coming back in real commonly. So perhaps that we'll get that opportunity, is to figure out who are the people especially at risk for recurrent heart failure. Your second one is obesity, and that's been so discouraging, having seen the development of the obesity drugs and programs. Obesity drugs out there, almost all of them to be acceptable are 5 to 10% drugs. There are a couple that are 10 to 15% drugs, and then we have gastric procedures and bypass, which are 30% procedures, but they're expensive procedures, and they're certainly not a solution. We don't have a very good way to turn that one around at all, so I think we all lament that with an insidious increase in weight. So for instance, we like to think about heart disease as age-driven. James Meggs and I did a diabetes prediction model in Framingham several years ago. And in Framingham, among middle-aged people, diabetes is not age-dependent at all. It's driven by the metabolic syndrome variable burden. And that's probably true all the way down to age 20. I don't have data to support that. It's your burden, and you're obese, you're going to get you're going to triglyceride, glucose, blood pressure abnormalities, and you're going to slide into diabetes a lot sooner. So, and that's going to affect how our burden too. We're going to have more people with diabetes and fewer heart attacks, but all these risk factors to manage. It's changing the complexion of how we care for our patients, even before the first event. I agree.
One more question? I'll do a quick question to close it. Going back to diabetes treatments, as you said, we work on many of them, many trials around the DCRI. A little anecdote, as TICOS ended, when the results were presented to the operations team, there was some disappointment. Like, the company was happy with the results. It met all the goals. There was some disappointment among people. It's a negative trial. The trial was designed to be negative. But so is there hope in any of these classes, any of the research that you're familiar, that we will have cardiovascular benefit derived by any of the glucose treatment classes, or we should just get that idea out of our mind? These are not statins, they do different things, and then see them in that context?
That's a tough question. So this was addressed recently for is LDL cholesterol, for instance, a surrogate for cardiovascular disease risk. That was recently debated as some of the recent PCSK9. And most of the variables that we can measure that are continuous measures are probably logarithmically associated with vascular disease risk. Some of them have very mild gradients. I think glucose has a mild gradient. So if I can get you from an A1C of 9 or 10, any way or shape, down to 8, I'm going to win. But you can't play like that in the United States, starting at 8. You're getting into the very flat part of the relationship between the measure and the outcome. Newer drugs, almost every newer drug is premised as a second drug. So it makes it even harder. And so I think we have elements of this for LDL cholesterol, for glucose, and for blood pressure. And the older scientists and clinicians in the room would say, he's talking a little bit about the J-shaped relationship again. Well, you can call it that, but it also is a physiologic relationship. Most of our relationships between continuous measures and vascular disease outcomes are not linear all the way down to 0. You're going to get diminishing returns. And the harder part is many of the molecules that we're studying for interventions are secondary molecules we're adding on top of an extremely well-accepted therapy. Statins are a good example. So you have a trial, statin plus the second drug. You have to have the statin, so we have active controls. It's not a simple arena anymore. I think the biggest challenge is the one I've alluded to. The big ball out there for diabetes is how we're going to stop heart failure. This is becoming the final driving endpoint, and we're no longer just the MI at-risk patients. It's probably the 5, 10 or more year risk factor burden that's going to drive them into heart failure. And it's going to be for both type 1s and type 2s. We're winning the atherosclerotic war, but as all the hospital admission data would suggest, we've begun to win the heart failure war. So.
Thank you very much.
Galen, you have a question?
Peter, why did they go into heart failure?
Gosh, I think that's why I'd like to see some really well-designed screening studies. At times at the heart meetings I go to the imagers, I'd like to see some even studies in type 1 diabetics 25 to 40 years old with a variety of modalities to look at study cardiac function and to prospectively follow those people. We have no indication to do that. Those people are likely to get heart attacks between 45 and 60, but we don't have real good guidelines for any of them. We certainly, for type 1 diabetics, they're doing very well with modern care, but they are probably the most vulnerable when they're getting into 30 or 40, because they've already had diabetes typically for 20 years.
Where's your nickel? Is your nickel on big vessel coronary disease, small vessel disease, or Schmidti-Yakupova, something else?
Probably, I would say it's probably not on coronary artery disease. I think it's on muscle or microvascular disease. Mike Zile's trying to go after some of this. Who's a basic scientist, clinician investigator at MUSC. Some of the newer drugs, of course, are going to probably change the equation, and I hope for the better for heart failure. The drugs that don't have names but just numbers that have just had recent major favorable outcome trials.
One of the problems we've got is we tend to drive heart failure into ischemics and non-ischemics. That seems like such a reductionist way of doing things, and because I think if what you're saying is correct, then where do you put the diabetic who goes into heart failure and never has really had a frank ischemic event? Because obviously some of them don't have the kind of nervous systems, the autonomic nervous system that allows them to have pain. So the absence of pain really doesn't help you. And I think we've just done I don't think we're doing a favor by taking, I don't think we're being constructive by driving heart failure into ischemic and non-ischemic categories.
So I agree with the pain, but there's also, if you're not having pain, you also probably have autonomic abnormalities too. So they may be very inefficient, the peripheral neuropathies are more than one type of neuropathy. And autonomic neuropathy may be helping to drive some of this in the heart. They get abnormal, R-to-R intervals with all the types of electrocardiographic, long-term, Holter types of studies. You see that. You even see that with insulin resistance before they're diabetic. So you've been doing this for 20 years, and you have a heart that's not squeezing at the right way and relaxing at the right way. Maybe that's predisposes towards
So
this.
maybe this is a neuropathic heart failure.
Yeah.
think
Well, I
we
don't
should-
have the answer, but I mean, those are the types of things. It would be some focused research on this and/or leadership on it. It's one of the big challenges.
Okay, thank you very much. We're running out of time, but it's good for you to continue discussing here. But thank you, Dr. Wilson, for a great presentation, stimulating discussion.